On behalf of our entire team, I want to thank you all for joining us today. And most especially, thank you for everything that you are doing to help patients during this challenging time. My name is Mike Casamassa. I am the Vice President of Solutions for Henry Schein, and I will be your host today. If you're joining us for the first time, our objective with this series is to provide you with new information, resources, and tools to help you navigate this pandemic. Today, we're going to be learning about a company by the name of VisualDx, and their product is clinical decision support, which can help you build informed diagnoses by providing fast, context-sensitive, and visual guidance. I'll share with you that this technology is absolutely going to be indispensable in the future, especially as telehealth and remote patient monitoring become the primary method of delivering care. Before I introduce the co-founder and CEO of VisualDx, we want to ensure that you have a quick overview of the webinar platform. As you can see, the control panel is located on the right-hand side of your screen. If you look at it, the button underneath it is in red. It says all attendees are in listen-only mode. We will not be using the raise your hand feature today. Underneath that, you'll see a little question mark, which is an opportunity to ask questions. If you click on this, you can submit any question throughout the presentation, and we will address those questions at the end. And last but not least, there is also a chat icon, which you can click on anytime during the session and go ahead and chat. So let's get into it. I have been very, very fortunate to come across many unique and progressive and highly disruptive and relevant businesses in my 20 years with Henry Schein, and certainly VisualDx falls into that category, which was co-founded by my guest, Art Papier. Art is a clinician who also happens to be a visionary technologist, and he has built a best-of-class clinical decision platform. So Art, I want to thank you for joining us and sharing your insights, and I want to pass the presentation over to you.
Mike, thanks so much for that hearty welcome, and it's a pleasure to be here today. This is going to be a talk on artificial intelligence, clinical decision support, and telemedicine. And the way I'd like to begin is to frame it. And I want to frame it by bringing into the discussion, of course, COVID. And through the talk, I'm going to weave together a story about how AI is part of clinical decision support. And that telemedicine and virtual medicine obviously have become a really key factor in care delivery in these uncertain times. And then move on to really sharing some thoughts about machine learning and artificial intelligence and talking about patient satisfaction, which ultimately is the most important thing, is we're doing technology to improve care. And so the elephant in the room is COVID. You know, it's rocked everyone's world, and it's worldwide, and it's affecting everyone, and it's affecting medicine. And so during this presentation, I'm going to really try to weave in our experience now at VisualDx, what we're hearing from our clinical users about the impact of COVID as it relates to the use of decision support. So another large frame for this would be thinking about the extraordinary change that's gone on in healthcare. Since I was in medical school in the 80s, we really were a system of memorization. We didn't have computers at all, certainly no smartphones. We didn't even have Palm Pilots at that time. And we really were unaided decisions, and we would follow the attending around on rounds, and the attending would be an all-knowing oracle that would amaze us with their memory feats. And now when we teach our students and residents, we're modeling information acquisition. I mean, certainly we need to memorize ACLS and emergency information, but when there's time to think, we're now seeing this transition to students, residents, and clinicians using information, using evidence as we make decisions in the exam room. So we're really moving to be more process-oriented around information as we take care of patients. And so then that information with patients can also be virtual. So this is just a screenshot of a professional interacting by video with a patient and checking data within Visual DX. And one of the broad brushstrokes also is to think about the context of error. And this is an infographic we created to kind of show how difficult it is, say, to be an emergency physician that has to handle so many different chief complaints, fainting spells, chest pain, breathing difficulty, heartburn. When you think about that emergency physician or any generalist, really, the range of complaints that they have to handle out of their brain every 10 or 20 minutes is fraught with challenges. And in this infographic, we're showing that of 20 patients, 2 will likely be in error. And this data is from the National Academy of Science study called Improving Diagnosis in Healthcare, where the National Academy of Sciences in a 2015 report said that 76,000 Americans die each year from diagnostic errors. So there's an estimate of 10 to 15% of all diagnoses being wrong. And there are reasons for this that have to do with cognitive mistakes that happen in the exam room. I'm sure many of the clinical listeners are aware of terms like premature closure or anchoring bias or representative bias. Representative bias is an interesting one because it really speaks to this idea that variation in presentation is really important in clinical medicine, that diseases don't always present like the textbook. And so it's really difficult to know all the variants of a disease, and especially when they're changing quickly. If we think this in the context of COVID, 3 months ago when we started in this world-changing crisis of COVID, we were thinking COVID was really a respiratory illness with fever and cough and very much a flu-like illness. And then we learned about loss of the sense of smell and taste, and some patients just having headache, some patients having diarrhea, and now more recently in our world of dermatology, this idea of COVID toes, a chilblains or perniosis looking rash, and then also more recently the multi-system inflammatory disorder with children presenting like they have Kawasaki's disease or toxic shock syndrome. So there's really a lot of variation in the presentation of COVID and also in the severity, obviously, of COVID. And keeping up with that can be really difficult because it's changing so quickly. And so the idea is that the computer plus the brain is more powerful than the brain alone. So there's awful lot of hype in medicine about man versus machine, kind of like the computer beating a contestant in Jeopardy, computer beating the doctor. That's not really what's going on here. We're really talking about augmented intelligence, not artificial intelligence, where the computer-based information, whether it's machine learning, artificial intelligence in general, rule-based systems, Bayesian systems, doesn't really matter. It's any type of computer-based information that's going to help us make better decisions in that exam room. And so why do we need help? We need help because medicine's challenging. This is a patient that we saw in a study that had 3 hospital admissions in 6 months. And of course, if you see those pen lines on the skin, it's kind of suggesting that the emergency physician was checking to see if the redness is ascending, that maybe this is a case of cellulitis. And many of the clinicians on the phone know that this is not cellulitis from just looking at it being bilateral. So these are 3 hospital admissions in 6 months for the wrong diagnosis. And research shows that 30% of patients admitted for cellulitis do not have cellulitis. And this study on the left was our study, both at UCLA and here in Rochester, New York, University of Rochester. A UK study and a more recent study at Mass General showed it was 30%. So it's right in there at 30%. Patients admitted for cellulitis don't have it. And this leads to unnecessary IV antibiotics, wasted expenses on lab tests, unnecessary hospital stays, and patients getting C. difficile and MRSA. And it adds up to a boatload of wasteful spending in healthcare. In fact, more than $1.3 billion are spent on these unnecessary admissions for cellulitis. So when physicians don't know what it is, or they think they know what it is, and they're searching for information, what do they frequently use? And we would argue that many, many clinicians use Google. Some use UpToDate, some use other electronic resources, but we certainly see many clinicians Googling information quickly because it's expedient. And our question is, would you fly on this plane if your pilot only had Google to navigate? I don't think you'd fly in that plane. I think you'd turn to the left when you got on the plane and saw this, you'd get right off the plane. So the question becomes, well, why do physicians fly with Google and just kind of ad hoc search? And this works when there are few variables. And as I said, the history of medicine is really a memory-based history. And so when you have few variables, say as the Wright brothers, you need to know which way the wind's blowing to push this aircraft into the wind to fly. But it's not the case for complex systems. So if you were trying to fly this by the seat of your pants, you'd have a lot of difficulty. So that's a complex system. And so is this. So your typical ICU, and you don't really have to be in the ICU to realize how difficult and how complex medicine can be. And so we have to start thinking about how do we augment the brain to handle all the data? And when we think about medicine in terms of aviation, we really are honest with ourselves in contrast to our pilots who are highly standardized in their procedures. We honestly don't have universal standards for how we problem solve. It can be very regional, it can be really based on who trained you and where you trained. We have some physicians using Google, some using UpToDate, some using Clinical Key, some not looking things up, some using books. Some are just strictly memory-based. There's really few feedback loops. The Federal Aviation Administration is all about feedback loops when there are accidents. Often the final diagnosis for a patient doesn't make it back to the original physician before they sent that patient to the consultant. And so crashes can go unrecognized, and generally speaking, the medical pilot performs differently frequently. So pilots don't use Google on final approach, so why do we clinicians not have a process? And so that's what we've really been dedicated to be thinking about at Visual DX, is how do we create a cockpit for professionals and patients? How do we improve decisions as they are made? So we believe that computer-based information should not just be a book online, that it should be problem-oriented, meaning that you design your information flow around patient symptoms in addition to diagnosis. And that information needs to be contextual. And this is part of the definition of clinical decision support. Contextual means that the software is interpreting, say, the age of your patient, the gender of your patient, it's accommodating the medical history of the patient, and really giving you information that fits the context. So as another example, a patient that's immunocompromised typically has different therapeutic recommendations. So it's all possible to build these systems to contextualize information to the uniqueness of the question that's in front of you with your patient. So we're thinking about the need to design and develop tools that are problem-oriented, contextual, and visual. So we don't think that you have the time in the exam room to read a lengthy treatise on a diagnosis, that it really has to be concise and pithy and synoptic. So what we've done is we've taken the diagnosis list and created a graphical display. And when we started, we were focused on dermatology for non-dermatologists. And then over time, Visual DX broadened to handle any chief complaint across medicine. So if you look on the upper right, it says cubital tunnel syndrome. And you see a diagram that explains that that diagnosis has hand pain, muscle weakness, numbness, and paresthesias in an ulnar nerve distribution. So what we've done is we've created these diagrams, these graphics that we call sympticons or symptom icons, so that you can compare the symptom patterns between diseases, or you can look at pictures of rashes or radiographic images, so that you can really instantly get the flavor for what the disease is about, rather than having to read a text online, go back in your browser, hold it in your memory, go read another text and try to hold that in your memory. So we're really trying to set up a comparative view. And I mentioned representative bias in terms of the variation in presentation. And what the system does is it accommodates variation, which means that you can search by, say, on the left, facial droop and joint pain. And because you didn't put in a rash feature, you're going to get that diagram that tells you the symptom patterns that are possible in the early disseminated form of Lyme disease. On the right is a different search by a different user, say, of rash that has a target or bullseye shape, and then the system adjusts the interface and shows you the rashes. So Lyme disease is a great example because some patients present with facial palsy and they get diagnosed as potentially as Bell's palsy, when in fact it's Lyme disease triggering the facial palsy. And so alternatively, you could present with Lyme disease with neuropathy and you're in your late chronic phase of Lyme disease. So we have to build these information systems to accommodate the challenge of variation in presentation. The other area that's really important in clinical decision support to consider is the need to get decision support into the workflow of the EHR. So there's a standard that's evolved called the HL7 FHIR standard. And the FHIR standard allows third parties like VisualDx to integrate into the EHR. So we've been engineered to this standard for about 4 or 5 years now. This is a screenshot of the Cerner EHR where VisualDx is picking up the med list and the problem list, the age and gender of the patient, and expressing the start and stop dates of problems and medications as a timeline. And then you can click on a medication that you're interested in because you see that that medication is temporally related to the onset of the symptom. And when you click a medication, it can bring up the drug reactions right inside the frame of the EHR. So you don't have to enter or type in the med because the clinical decision support system, VisualDx, is picking up the medication from the med list, presenting it with you graphically. You click on the med, it sends the med code up to the cloud, and we send back the differential diagnosis of the drug reactions for what you've entered. So that's an example of the interoperability of decision support inside the EHR. And this can be engineered and is engineered into Cerner and Epic, and now other EHRs are also embracing this FHIR standard, so third-party innovators can put intelligence into the EHR. So after this COVID earthquake, we really should think about how we're so dramatically shifting, and obviously one of the things that's happened is medical offices have been closed. They're starting to come back online in many states. But some patients really remain in fear of the office, and we're doing more telemedicine. And I think one of the things that we all have to deal with now, both in the office and online, is anxious people. And really, really important that we do our best to allay their fears. And what we've learned from our users is that they're screen sharing evidence from VisualDx, say, to show a patient that their symptoms are not COVID related and to show them what their diagnosis is. So there's real changing priorities. There's a realignment of payment and shifting rules. We now have compensation for virtual visits, like there are in-off visits. We have at least the temporary relaxation of HIPAA. So many sea changes are underway. And so the telemedicine idea is that you can have decision support up on your screen and share your screen with the patient to calm them down. You also can be your co-pilot, like you're talking to your patient through Zoom or through your iPad or FaceTime or Skype, and you're working in your EHR, you have your decision support open in a window. You're able to quickly check a therapy dose or a testing recommendation, and then you can share information with your patients. And so we have in Visual DX, we have the ability to ask the patient, well, let me send you an email from this system, which is HIPAA compliant, and sends a patient a diagnostic information sheet. And then, just like when the patient leaves the exam room, virtually has the same need where you want the patient to know what you said. And of course, when they hit the parking lot, they often thinking, what did the doctor say? Or you close that window from the virtual visit. So one of the techniques we have is to be able to quickly say to the patient, give me your email address and I'll send you a handout on that diagnosis. So as I said, patient anxiety is a constant. We really have to be aware of that, and we have to really do our best to reassure people. Diagnostic error risk reduction, I touched on this in the beginning. We have historically a problem with a diagnosis, particularly in the emergency department and in other areas of clinical medicine where there's ambiguity and there's time pressure, and we need good information. And COVID's really going to bring this out. Obviously, there's another bias called availability bias, which means that you diagnose the first things that comes to mind. And, COVID is in our dreams. We're thinking about COVID all day long. But what happens if a patient presents with cough and fever and has bacterial pneumonia or a different reason for cough and fever? So there's tremendous variation in the presentation of COVID, and diagnosis is a challenge. And so there's risk for us. So using decision support systems can help us to double check and to make sure that we don't miss things. So let's segue over to AI and bring this all together and talk about the subcategory of machine learning. So machine learning is a subtype of AI where we can train these algorithms on data, and particularly image-based data is an area that we're making great progress. So the fields of radiology, ophthalmology, pathology, incredible progress there. And we're teaching the software in our world to learn from images. So I'm going to play a quick video here.
When you or I look at this creature, we know it's a dog. But when a computer sees him, all it sees is this. How do I get a computer to recognize that this photo, or this one, or that one, is a photo of a dog?
It turns out that the only reliable way to solve this problem is to give the computer lots of examples and have it figure out on its own the average, the numbers that really represent a dog.
Here's where deep learning comes in. As you might recall, it's a program based on the way your brain works. And it looks something like this. Here we have layers of sensors or nodes. Each feeds information in one direction, from input to output. The input layer is kind of like your retina, the part of your eye that senses light and color. In the case of this photo of Buddy, it senses dark over there, light over here. This information gets fed to the next layer, which can recognize basic features like edges. That then goes to the next layer, which recognizes more complex features like shapes. Finally, based on all of this, the output layer labels the image as either dog or not dog. But here's the kicker, and this is what's revolutionary about deep learning and neural networks. At first, the computer has no idea what it's looking at. It just responds randomly. But each time it gets a wrong answer,
information flows backwards through the network saying, you got the answer wrong. So anybody who was supporting that answer, your connections actually get a bit weaker.
and anybody who is supporting the right answer, their connections get stronger. Back and forth, it does this over and over again, until, thousands of images later, the computer teaches itself the features that define dogginess.
So that's a quick overview of a form of machine learning. And
This is a 3. It's sloppily written and rendered at an extremely low resolution of 28 by 28 pixels, but your brain has no trouble recognizing it.
so this is a form of machine learning where they're using the example with the dog to show how we train these algorithms. And similarly, we've been training skin images to learn through these algorithms what's in the picture. And one could train imagery on diagnosis, but what we've done is we've trained the algorithms not just on diagnosis, but on the skin lesion morphology and the diagnosis, and also the skin type, is it light skin or dark skin? And we're extending this research to see if we can figure out multiple different classifiers for what's in a skin image. And so the next slide shows different types of skin lesion morphology. So dermatologists, of course, look at rashes and the brain is triggered in instantaneous pattern recognition, say that's a bulla, that's an erosion, that's a vesicle, that's a macule. And so the images have these tags on them, hundreds of thousands of images with these word tags. And then you take the machine learning algorithm and it ingests all the images and the tags and develops a model to be predictive about what an image has for the tag. So you take a photo and you run that algorithm and it's going to predict what it thinks the morphology is. So we've been training on morphology, and we've been training on imagery in light skin and dark skin and variation. So one of the wonderful things about machine learning of imagery, the more images and the more variation you put in, the smarter it gets. And so we've been doing this for years, and we've been making a lot of progress where you can take a picture of a lesion, and whether it's light skin or dark skin, and this is an image of varicella in dark skin, and you can see how different varicella can look in people that are deeply pigmented. And these algorithms actually can work with this data and pick up these differences and these nuances. And it's just a revolution, really, that's come across all the visual specialties in medicine. So there's incredible progress now in ophthalmology. There's diabetic retinopathy. There's an approved FDA app for that. And in radiology, just amazing work going on where the machine learning will function as a second read for the radiologists, hopefully helping them to avoid error. So this is an image of a pediatrician here in our town using the app we developed to take a picture of a rash. And then this is a picture of Dr. Brown, who's the chair of emergency medicine in Baltimore, who had this patient present with a rapidly growing lesion. And I'm going to finish the presentation by doing this live and show you how he used AI, machine learning, in the emergency room to get a better differential diagnosis. And so we'll also highlight that when Dr. Brown did this, he did it in front of the patient. He was comfortable saying to the patient, well, we have a new app. We're going to give this a try, and we're going to explain and think out loud with you. And he said that this running commentary they did with the patient was fascinated and really appreciated the education as they were thinking and talking it through in the emergency department cubicle. And that's really an incredible change in medicine, because when we started 30 years ago thinking about these ideas in the 1990s, doctors really would go down the hallway to look something up. They didn't want to say to the patient, you know, I don't know, and change that image of physician as Marcus Welby, that was a pure genius. Physician didn't have to look something up, to now that we have many, many more professionals that are comfortable saying to the patient, you know, I don't know if your medication causes that problem. Let's look it up. So what's next is really thinking about machine learning and AI for the patient. And we've worked on an app called ASA, and this is freely available right now through the Apple App Store or Google Play. You can search ASA and just download it. And ASA allows you, a patient, to get triage, self-triage, or education on common skin disorders. So we're using that same machine learning capability. And so the way it works is you launch it, and you can take a photo of yourself or a loved one or a friend. And this is actually taken by a non-physician or product manager at a wedding. And his cousin at the wedding said, Joe, I hear you're working for a company doing something with dermatology. I have this on my hand. So he took this picture on a deck at a wedding, and he entered her name, and he chose the skin type, and he progressed, and he then clicked that it was on the back of the hand and said it had been there for days and there was no itch, and it created a profile. And then it gave him a differential diagnosis, but of course they didn't call it a differential diagnosis, but they were wading through different ideas, and they were looking at Lyme rash with an I, not Lyme disease, but Lyme rash that's caused by sunlight and the juice of a lime or a lemon, called phytophotodermatitis. And then when they saw this image, they realized this looked just like his cousin. And they read that this can happen from limes and lemons, and figured it out on the deck of the wedding. And so, you know, simple things sometimes don't need to reach us. And we know that people are using Google, they're using WebMD. So the question is, how can doctors play a role in supplying the best possible information to people so that we can drive better care, and we do it safely, and we think about unintended consequences, because we certainly don't want people, you know, looking at a pigmented lesion and say, oh, that's nothing, and not come to the office. So we build into these systems safety valves so that we don't miss complicated diagnoses, and we try to drive more appropriate referrals and more appropriate care. And then these kind of apps can refer for telemedicine, or find a local doctor, or make recommendations for, you know, common things like warts or dry skin. And we presented a poster at a national meeting, Society of Investigative Dermatology, and we showed that overall results, we could get into the 88% level of getting the right differential together on a skin picture. And Visual DX got a shout out from Tim Cook, which we always mention, because Tim Cook used Visual DX as an example because we're using Apple's technique called Core ML on the iPhone. So when you take the picture, the analysis happens incredibly on the phone, not in the cloud. And that's important from a HIPAA point of view and privacy. So our company never sees the patient image. The patient's image is in temporary memory of your phone. And then as soon as you click out of that app, then the image goes away. So Tim Cook gave us a shout out for innovating with Core ML from Apple. So that's the conclusion of the deck. I wanted to jump over to the phone and share my phone with you and just show you how you can be on the phone and take a picture. And so let's go over to a stored picture, and there's the image from Dr. Brown, and you click on you take the picture of the patient, and then you click use this photo, and it will say analyzing photo, and you'll see now it describes the skin exam. And so Dr. Brown, who's an emergency physician, says to me, Art, I'm an emergency physician. I don't think in my 30-year career I've ever called anything a friable papule. It's just not language we use in emergency medicine, at least I don't. But I saw your icon that was a red, bloody, round lesion, and I said, well, that looks pretty close. So he clicked that, he hit next, he put in the patient age, hit next, and he had to choose, is it a point lesion, a growth or a lesion? Is it a limited area of skin, or is it multiple areas? And so he chose that it was a point lesion, and then he put in it was on the finger, and then said no itch, and that it was there for a couple of weeks, patient said, and the patient looked well, and then it just gave him a differential. And he was looking, he saw the top photo had a bloody lesion, and so he started swiping with his finger to see other examples, and he quickly got to this image, which he pinch zoomed. And when he told me the story, he felt looked like a very small version of what he was saying. So he read in the emergency room that lobular capillary hemangiomas, also known as pyogenic granulomas, are rapidly growing. And so he made this differential diagnosis by taking a photo, inputting a few answers to questions, and along the way, he was exposed to the language of dermatology. So hopefully over time, he'll become more familiar with some of the skin exam descriptions that we use. So as another example, you'll see on a very different looking image here of this rash, it says use this photo, and it says excoriated skin lesion. So the machine learning is working on skin lesion morphology, but it's also working in the background on the diagnosis itself. And this example of clinical decision support is bringing together the skin lesion morphology, the diagnosis itself, the answers to the question like body location, age of the patient, itch, no itch, fever, no fever, how long they've had it, and it sums that information up to give you a differential. It never says it's 99% chance it's blank. It's always giving you a differential. So again, the idea is computer plus brain is more powerful than the brain alone, and we certainly don't want physicians to just rely on AI. We want them to use it as a tool. So I'll end there and be open for questions.
All right, Art, thank you so much. That was absolutely fantastic. We already have some questions coming in. I'm actually going to do them in reverse order for a reason. Art, you presented a lot on dermatology. One of the questions is, beyond dermatology, what are the most common specialties that use clinical decision support? And if you don't mind, I want to add to that. Could you talk about the generalist versus the specialist use cases, with Visual DX so everyone understands?
Yeah, that's a great question. I'll start with the specialties that are impacted by decision support. So certainly we're seeing this like quickly evolve with forms of decision support embedded in the EHR to help with questions about, appropriateness of different tests or different therapies. There's now embedded, I think by law, in the EHR decision support on what's the most appropriate radiologic study. Should I order an ultrasound or CT or MR? And we certainly see areas of decision support for the critical questions of medicine, which really are what's the diagnosis? What's the safest, most appropriate test to order here? And that can be radiologic or laboratory test. And then in context, what's the most appropriate therapy, right? And so as medicine becomes more specialized, the specialties start to evolve resources that they're aware of, like, an oncologist probably is using, in addition to the primary literature, different resources to help them stay on top of the latest oncologic therapies, which is really difficult to stay up on top of if you're a generalist. And that's why we so often rely on the oncologist for therapy. So, the faster growing specialties will see more and more decision support, but our focus in our work is really thinking about the generalist. And, general medicine really has been short shrifted in the sense that, reimbursement is really for procedures, and we really haven't given our generalists the credit they deserve for how difficult office-based medicine is, or the emergency department, where patients can come in with any complaint. And we think that you'll see decision support evolve for the generalist from the most difficult areas to the least. And one of the reasons Visual DX has been successful is because dermatology is universally said to be difficult by non-dermatologists. So that's been the wedge for us to get physicians thinking about augmenting their brain in other areas that are important. And one that we're working on heavily is orthopedics and musculoskeletal complaints, because back pain, knee pain, all forms of different joint pains, very, very common in primary care. So I would say that in medicine, we want to really arm the generalist with information that's contextual to the most difficult problems they see.
Okay, great. Let's continue on. Do you feel clinical decision support is now widely recognized as an area we need among providers?
I think that we're living through an historic transition, and it's not widely recognized because there's tremendous variation in the way people practice medicine. And the educational system has really been focused on taking your board exams, on basically memorizing and answering multiple choice questions. The examination of residents and students and even CME isn't really based until recently on the idea of knowledge acquisition, but I've learned that internal medicine recently has made part of their continuing medical education to include open book, to be able to use up to date during the exam. So as we live through this transition, I think you're going to start to see that students and residents and doctors will be trained and examined in how to use tools. And the analogy is perfect with pilots. I mean, you get checked out on the instruments when you learn how to fly a 737 or 747 or 777. You're being trained in the instruments and you're being examined in the instruments. And so medicine has become tremendously complex, and we really have to start giving professionals professional tools that solve problems. And of course, Mike, part of the problem is the disaster of the electronic health record. That the electronic health record has been a real burden for many, many physicians. And, we have apps on our phone as burdensome. We find our apps usually to be pretty easy to use. So that's another insertion point in decision support is the phone, because there's really zero barrier if, say, you're on the go as an emergency doctor or a hospitalist to reach into your phone and to check something quickly.
Yeah, well, interestingly enough, I mean, you just showed how unbelievably intuitive your technology is, including the desktop version and of course the app version. Everyone expects things to work like Apple, but very few things do, especially around the EMRs. I'll also share with you that I recently saw a statistic that stated somewhere around 52% of the health systems out there, including the owned managed and affiliated practices do not use any form of clinical decision support technology whatsoever. And I guess on the flip side, you could say, well, that means 48% do. However, clinical decision support as a category is pretty broad. So it really does suggest that the adoption is not quite there. But I think with the prevalence and really the move to telehealth, I think you're going to start to see that change. Let me ask you a quick question, because it does also seem like the world is going to become a lot more complicated in terms of patient-generated health data. How is the increase and really the rapid increase in patient-generated health data going to complicate matters in terms of delivering effective telehealth, and how can clinical decision support potentially help solve some of the issues generated by the abundance of information that will be made available?
Yeah, so, TMI, too much information or helpful information? Will big data solve these problems? Will big data be able to sort out like what's really relevant information and what is information that is not clinically meaningful? And so, you can monitor people, and, you can wear your Fitbits, and you can look for patterns. And I think software will see patterns we can't see as individual clinicians. But the challenge is there's just so many different data feeds, and we all have to live our lives. And like, are we medicalizing life? Are we really bringing value to people? Or do we just have them stressed out because there's too much data? And there's just so much research that needs to be done. And, the hype always precedes the value. And, I'm a bit skeptical on, AI and machine learning putting breakfast on my table. And, I think we all have to, doctors naturally are skeptics. We're all pretty skeptical, like, prove it to me that this is really going to make a difference in people's lives. So with that skepticism, I will say that the visual side of AI is really important. That, the techniques to analyze an image is moving at just incredible speed, and it's going to have huge impact across healthcare. In terms of people at home sensing their weight, their temperature, their mood, their sleep patterns, etc. It's going to be a mixed bag. I mean, we're going to find a lot of patterns we were unaware of, but we'll also be challenged to separate out the noise.
Yeah. Well, we got a couple of questions coming in that are really speaking to kind of some numbers, and I want to start this off by asking you if you can touch upon the cost of misdiagnosis and the business case for investment in this type of technology. Also, maybe before you answer that, Art, I know that your software has a definitive improvement in clinical diagnosis when used. Can you maybe give some highlights in terms of what is the expected improvement rate in terms of diagnostic accuracy when using clinical decision support, specifically Visual DX, that you've seen and quantified? And then maybe talk a little bit about the ROI associated with this technology.
Well, the initial studies we did years ago showed that we more than doubled the accurate diagnoses when we had physicians randomized to solve difficult cases from the literature. But that was a simulated study years ago. And then we started getting experience in the real world. And one of the things that we did, we asked physician users, nurse practitioners as well, to estimate how much time Visual DX was saving them each day. And this wasn't just for diagnosis. And it's a really important point that the challenge in medicine is not only diagnosis. There's a challenge on treatment, a challenge on testing, and there's also a large challenge on patient understanding. And what we learned about our success was that though we have a very, very sophisticated platform for searching by symptoms and labs and signs and countries to get a differential, we learned that many of the users were using the pictures in Visual DX to educate the patient at the end of the visit. And they were saying that patients would often, we hear this all the time, that patients are on Google or WebMD, they're coming to the physician with their preconceived notions, And they're actually arguing with the doctor, saying, "Doctor, I don't think I have what you say I have." And we've had stories from our users where they say, the patient was insisting, as one example, that there's no way that poison ivy could have such huge blisters. And I went to Visual DX, in 5 seconds, I had a picture of a huge bulla covering the hands. And that's the only thing that settled the patient down and stopped the argument. And that saves time when you can show a patient palpably that you're using a professional information tool. And so it's not just about diagnosis, it's really about the entire patient experience and moving over to showing the patient that you're comfortable using professional tools. And these are tools they don't have, because Visual DX is not something they're going to find in the internet. So I'm blank on the first part of the question now.
Yeah, I think you got, well, I asked you about what is, what is diagnostic accuracy improved to with Visual DX? Do you have any numbers to say the diagnostic accuracy goes up X percentage, when you use this technology?
In one study that was run, still not published, out of Germany, where it was German family physicians using our English version. We now have a version that's searchable in German, but at the time in English, it was around 37% that it improved. And it's a very, very difficult thing to measure, because you would have to go back, and if you did this in the real world, and have a second set of physicians confirming what the actual diagnosis is. But we've had some remarkable case vignettes over the years. Like years ago, a child who was being sold as having a rash from strep, and the emergency physician who was checking the patient out for the physician assistant used Visual DX and started to believe the patient had meningococcemia, and the patient had positive blood cultures for meningococcemia and walked out of the hospital 2 weeks later without loss of limb. And so, and that physician said, just the fact that I could have professional level images showing me the difference between these rashes, it made a world of difference for me. But again, brain plus computer, Mike.
Gotcha. Okay, and look, at the end of the day, I think it's pretty clear that with clinical decision support, you're going to improve diagnostic accuracy. Without a doubt, what you just said about the patient engagement piece, that's going to improve patient satisfaction. It should extract cost from the overall process. And if you think about it, it really does speak to value-based care, which easily the best definition for value-based care is delivering the best possible patient outcomes, but yet being accountable for the cost to achieve those outcomes. And it seems like clinical decision support can help in both sides. We do have a question.
That was your question I didn't recall, which about cost. And when you looked at that data we had on speed to answer from our users, saving them time, obviously, if you save a busy professional time, they can see more patients, or they can get a longer break at lunchtime, and you have happier doctors. And on the other side, in accountable care, as you're pointing out, every unnecessary referrals cost to the system. Every unnecessary admission for cellulitis is cost to the system. And so, both on the speed to answer, whether it's fee for service or not, but then also in a closed system or of accountable care, you really start to save money.
Yeah. And the other thing too is it's really non-disruptive to workflow, which I think is absolutely critical. And that differential can be built simultaneously as you're doing the exam. We do have one attendee asking what is the cost to use this. And I'll share the answer to that. Is we're a main distributor. This wasn't meant to necessarily be a sales presentation, more of really a content piece. Cost always is determined based on volume and the number of users, but generally speaking, it's around $400 per user per year. And I'll also share with you that any user that creates a differential diagnosis on this can oftentimes receive CME credit. So in many instances, just the cost of CME is covered by using Visual DX. So it is an incredibly cost-effective solution, $400 per year per clinician. And then on top of that, you get all these other ancillary benefits. So that hopefully answers the cost. There was also another question about the correct spelling of the app. And I do want to point out that the professional version, which can be used on a desktop and also a tablet, that's Visual DX. So you can see it on the screen here under Art's name. It's the CEO of Visual DX. The actual app that Art was referring to is ASA, which is AYSA, which is available in the App Store. And Art, is it also available for Android too?
It is, and the distinction is that ASA is a guide to common skin conditions only and covers roughly 200 diagnoses. Visual DX cuts across medicine. You can evaluate dizziness or diplopia or abdominal pain in Visual DX. It doesn't have to be a rash, and covers over 3,100 diagnoses. So it's Visual DX is the professional system aimed at diagnosis, testing, and treatment and patient education. And ASA is a 200 common skin disorder educational tool for people.
That's perfect. Okay, I think that's it. I think we answered all the questions. Art, I want to thank you for your time today, and certainly for all the attendees. I hope this was incredibly useful. It was a useful use of all of 60 minutes of your time. Certainly appreciate everything that you do, and I hope that you get something out of this and consider using some form of clinical decision support in the future, especially as care delivery in our country changes. So with that being said, I want to say thank you on behalf of Henry Schein, and I wish you the best of the days. Thank you.
Thank you, Mike.